Hello everyone, this is Ashley Hughes, and I will be telling you about my population intervention plan, which is addressing heart failure in geriatric patients. Heart failure is a potentially fatal condition in which the heart cannot pump enough blood to the rest of the body and is a chief public health concern. It is not only possible for an individual to have systolic or diastolic heart failure exclusively, but to have a combination of the two. Heart failure represents a substantial burden to the United States healthcare system and is liable for costs in excess of $39 billion annually and includes high rates of hospitalizations, readmissions, and outpatient visits. Heart failure is not a single entity, but is a clinical syndrome that may have different characteristics depending on age, sex, race or ethnicity, and heart failure cause. Although heart failure affects people of all ages, the at-risk population for this intervention plan is geriatric, which is defined as 65 years of age and older, men and women who live in rural Milam County, Texas. The prevalence of heart failure is over 5.8 million in the United States and over 23 million worldwide. As a result, the lifetime risk of a person developing heart failure is 1 in 5. Heart failure annual prevalence approaches 10 per 1,000 of the population after 65 years of age. The incidence of heart failure is equally found in men and women. However, African Americans are 1.5 times more likely to develop heart failure than Caucasians. Heart failure is the first listed diagnosis in 875,000 hospitalizations, making it the most prevalent diagnosis in hospital patients aged 65 years and older. Geriatric patients are considered a population at risk because aging is a risk factor that cannot be changed, and it can weaken the heart muscle. Additionally, older people may also have had comorbid diseases for many years that led or contributed to heart failure. Nearly 5 million Americans are currently living with heart failure, and approximately 550,000 new cases are diagnosed annually, which contributes to nearly 287,000 deaths in the United States each year. Heart failure is accountable for 11 million physician visits each year and more hospitalizations than all forms of cancer combined. Heart failure is a leading cause of hospital stays among people on Medicare, and over half of those who develop heart failure actually die within 5 years of being diagnosed. Furthermore, sudden death is common in patients with heart failure, and it occurs at a rate of 6 to 9 times that of the general population. The most pertinent reason the geriatric population is at risk is because projections indicate that the prevalence of heart failure in the United States will increase 46% from 2012 to 2030, making this morbid condition a priority in the healthcare industry. A census study of all geriatric persons living in Milam County was used to locate the at-risk population. Milam County has an estimated population of 24,871 people, and 19.8% of the population is older than 65 years. Accordingly, the incidence of the population that is geriatric is 4,924 people. By including each geriatric person in the population, the margin of error is 2%, the confidence level is 95%, and the required number of responses needed for surveillance would be 1,615. This would provide an estimated response rate of 20%. Demographics for my population were identified using the United States Census Bureau's quick facts about Milam County. The population demographics are 86.6% Caucasian, 9.8% African American, and 3.6% Hispanic or Latino. Females accounted for 50.6% of the population, while males accounted for 49.4% of the population. The method used to make initial contact to communicate the intervention is a letter that is mailed to each person in Milam County who is age 65 or older. This letter will notify each individual about the prevalence of, risk factors for, and the interventions and surveillance that will be included over 5 years of data collection and research, which can help mitigate heart failure. Recruitment will take place in media outlets such as local newspapers, on the World Wide Web, local radio stations, and flyers throughout Milam County. The recruitment advertisements will include a brief description of the study, state the study is for research and surveillance, not for treatment, include age restrictions and other qualifications for eligibility, benefits, time commitment, name and address of the investigator completing the research, location of the research, and name of the person to contact for further information. According to the United States Census Bureau, the median household income for families or individuals in Milam County is $38,929. The percent of those who live in poverty is 16.9%, and 81.4% of individuals are high school graduates, while only 16.7% have a bachelor's degree or higher. Furthermore, 14.8% of homes were found to speak a language other than English. This information is vital to know as it determines that advertisements and materials related to the research should be bilingual, and the information needs to be literate as a 5th grade level and below, and in layman's terminology. The selected population health model is the chronic care model. The chronic care model focuses on a population health strategy aimed at maintaining or improving health for a chronic condition. The chronic care model requires patient engagement, data access that identifies patient populations who would benefit from interventions, the ability of the healthcare team to manage patient fitness journeys, as well as coordination of care amongst other healthcare members and sites. The rationale for selecting the chronic care model with the population of geriatric men and women with heart failure is due to heart failure being a chronic condition. The chronic care model has 6 domains: organization of healthcare, clinical information systems, delivery system design, decision support, self-management, and community resources. The chronic care model assumes that the majority of care for patients remains with the primary care provider, who is supported by an integrated healthcare team that performs targeting and case management activities, but this is only an assumption. In fact, there are 4 major assumptions of the chronic care model. The first, reduction in the cost of chronic illness, is the major goal and is associated with improvements in health and the chronic care model. Second, the way to accomplish cost reduction is to concentrate on the highest cost patients in the chronically ill population. Third, primary care providers are not knowledge equipped to take on the task of chronic illness care. And the fourth is, patients will do better if their chronic disease management is largely removed from primary care providers and is delegated to a case manager and/or a specialist. The following is an example of how the model is applied to the selected at-risk population. A provider has a large population of patients with heart failure in the clinic, and he or she would like to know how well those patients with heart failure are doing. Organizational support is established by the clinic director allotting time and a small budget for research. Clinical information systems is accomplished by utilizing the clinic's electronic health record and querying the database to obtain total number of patients with heart failure, medication, diet, and exercise compliance, blood pressure averages, and any other relevant data to include lab work and those with a history of heart attacks. Quality improvement is then noted by determining that 400 patients have heart failure at the clinic and that only 40% of those have had blood pressures less than 140/90, and the other 60% have had uncontrolled or poorly controlled blood pressure. The provider then determines that the focus of the intervention plan is to attain better control of the 60% of patients whose blood pressures are greater than 140/90. Delivery system design is established through a variety of ways to improve the delivery of care that could improve blood pressure readings. This could be accomplished through phone calls, planned visits, group visits, or having patients come in to be seen for a focused assessment. Decision support and self-management support can be achieved through research determining that automated reminders via phone call or text messaging improve blood pressure readings as it reminds the patient to take medication or to take blood pressure to see if medication needs to be adjusted or changed. Then a trial of 100 patients out of the 400 with heart failure are identified as candidates for this new automated system at the clinic. Community resources are established by partnering with other clinics and healthcare agencies who are interested in helping fund or take part in the research for patients with heart failure. The specific quality improvement that will be addressed by this intervention is patients will have better controlled blood pressure, less than 140/90, when the chronic care model is applied in the clinic setting for patients with heart failure. By addressing high or elevated blood pressure, this can mitigate one of the risks and may help to prevent heart failure along with other interventions. The purpose of this population intervention plan is to reduce the incidence of heart failure in geriatric men and women throughout Milam County. This can be accomplished by incorporating the chronic care model's 6 domains into clinic settings and treatment practices, and thereby mitigating some of the risk factors that can lead to heart failure. Hypertension is a precursor condition in the bulk of patients who develop heart failure. By age 75, nearly all hypertensive persons have isolated systolic hypertension. Research trials have revealed that controlling systolic hypertension reduces heart failure rates. The lifetime risk of heart failure doubles in those with blood pressure greater than 160/100 versus those with less than 140/90. This gradient of risk is seen in both men and women in every decade from 40 to 70 years. In patients with hypertension, blood pressure target is less than 140/90. Since most patients with hypertension will reach diastolic blood pressure control once systolic blood pressure is controlled, the primary focus should therefore be on systolic blood pressure. In a study by Williamson and Company, evaluation of intensive targets in geriatric individuals with hypertension was performed. A multi-center randomized clinical trial of geriatric patients who participated in the systolic blood pressure intervention trial was evaluated. Partakers were randomly assigned to a systolic blood pressure target of less than 140 millimeters of mercury for intensive treatment and systolic blood pressure of greater than 140 but less than 190 for standardized treatment. The primary cardiovascular disease outcome was a composite of non-fatal myocardial infarction, acute coronary syndrome not resulting in a myocardial infarction, non-fatal stroke, non-fatal acute decompensated heart failure, and death from cardiovascular causes. Among the 2,636 participants, 2,510 provided comprehensive follow-up data. At a median follow-up of 3.14 years, there was a considerably lower rate of the primary composite outcome in the intensive treatment group versus events in the standard treatment group. Among ambulatory geriatric patients treating to a systolic blood pressure target of less than 120 compared with a systolic blood pressure of less than 140 resulted in significantly lower rate of fatal and non-fatal major cardiovascular events. Similarly, diet modification was shown to reduce the risk of heart failure by lowering the amount of sodium eaten to no more than 1,500 milligrams per day is one of the most important ways to reduce the risk of heart failure. Including high fiber foods in your diet, fiber helps move food along your digestive tract, controls blood sugar levels, and may reduce the level of cholesterol in arteries. Vegetables, beans, whole grains, bran, and fresh fruit are high in fiber. Diets should contain 25 to 35 grams of fiber each day. Ramon and Company conducted a randomized trial of this diet pattern for the primary prevention of heart failure. The researchers randomly assigned participants who were at high heart failure risk but had no heart failure at enrollment to one of three diets: a Mediterranean diet supplemented with extra virgin olive oil, a Mediterranean diet supplemented with mixed nuts, or a control diet advised just to reduce dietary fats. Partakers received periodical, individual, and group educational sessions and free provision of extra virgin olive oil, mixed nuts, depending on which group was assigned. The primary endpoint was the amount of major cardiovascular events. A total of 7,447 individuals were enrolled. 57% were women. The two Mediterranean diet groups had adhered good to the interventions, according to self-reported intake and biomarker analysis. A primary endpoint event occurred in 288 participants. The multivariable adjusted hazard ratios were 0.70, which is a confidence interval of 95%, for the group assigned to the Mediterranean diet with extra virgin olive oil, and the group assigned to a Mediterranean diet with nuts was 83 events, versus the control group with 109 events. Among individuals with high heart failure risk, a Mediterranean diet supplemented with extra virgin olive oil or nuts reduced the incidence of any major cardiovascular events. A specific quality improvement is to reduce heart failure prevalence in Milam County. A measurable outcome for this intervention is to reduce the prevalence of heart failure to 40% of the geriatric population. A second quality improvement is to gain better control of blood pressure in patients, as blood pressure is a primary risk factor for heart failure. A measurable outcome for this intervention is for 60% of the geriatric residents of Milam County to have blood pressure less than 140/90. In order to achieve these goals and outcomes, the defined at-risk geriatric population needs to be educated on the risks of heart failure, disease progression, risk factors for heart failure, lifestyle changes or modifications, and have increased healthcare access. Based on the proposed interventions and outcomes, the following information needs to be collected. If blood pressure is taken at home, and if she has the equipment to do so. Medication compliance. What type of diet does he or she have? Comorbid diseases. Race. If the individual already has heart failure or has a family history of heart failure. Recent lab results. A current physical examination, which would be within the last year. A chest x-ray if indicated. An electrocardiogram if indicated. An echocardiogram if indicated. A stress test if indicated. A radionuclide ventrilography or multiple gated acquisitions scanning if indicated, or a cardiac catheterization. Environmental information includes distance and availability to get to the nearest healthcare clinic, telephone access, a translator for non-English speaking individuals, if the individual has insurance, and education level for comprehension of plan, goals and outcomes, and treatment. The source used to establish and develop a surveillance plan was the World Health Organization's stepwise approach to surveillance of non-communicable diseases. The STEPS approach is based on successive levels of surveillance of different aspects of non-communicable diseases, allowing flexibility and integration at each step by maintaining consistent questionnaires and protocols to ensure comparability over time and across locations. The Peoria evaluation criteria is based off the following recommendations from the Preventative Services Task Force on self-measured blood pressure monitoring and self-reported eating habits. By combining self-measured readings and self-reported habits with additional support from the clinic through individual and group counseling, education, telephone encounters, provided equipment, ensuring medication compliance, and encouragement, blood pressure readings should be at the target goal of less than 140/90 for 60% of the geriatric clinic patients, and heart failure prevalence should decrease in the geriatric population to less than 40%. Evaluation should also show an improvement in other comorbid outcomes such as lower cholesterol and triglycerides, improved overall health status, and fewer relapses and hospital admissions. The health clinic will identify geriatric men and women who live in Milam County. An initial letter will be mailed to each individual who qualifies to be a part of the interventions, outcomes and goals, and surveillance plan. Next, advertising will occur throughout local newspapers, television stations, radio shows, and flyers will be posted throughout town. Then, education, equipment, food diaries, heart-healthy cookbooks, and telephone or other communication devices will be established. Data will be collected weekly, and adjustments with medication and diet will occur until target outcomes are at goal. Participants will be required to self-measure their blood pressure. They will be given a blood pressure machine for twice daily monitoring and a direct telephone number to their primary care provider and nurse at the clinic. Telephone monitoring will take place weekly to collect the data, and routine 12-week follow-up visits will take place. Additionally, participants will be required to self-report their eating habits. Individuals will be given a food journal and a healthy cookbook. They are to keep a log of all the foods he or she consumes and give that information to the primary care provider or nurse when weekly data is being collected and routine 12-week follow-up visits take place. A letter will be mailed to all applicable candidates who qualify to participate in the research study. Advertisements will then be made throughout Milam County. Applicants will then be established with a primary care provider and a nurse at the clinic collecting the research data and have an initial assessment performed and recorded. During the initial assessment, participants will be given the blood pressure monitor, food journal, and cookbook, a direct number to the primary care provider and nurse, and a 12-week follow-up appointment will be made. Data will then be collected weekly and evaluated for effectiveness. Medications, lifestyle changes, exercise, and diet will all be adjusted depending on each individual's need and ability to reach his or her set goals. The interventions will take place at the clinic that is collecting the data and at the participant's home, where he or she will perform the self-measuring of blood pressure and self-reporting of diet. The home setting could also be an assisted living facility or a nursing home setting, depending on the individual participant's needs. The two interventions are guided by the chronic care model. Organizational support is noted by the clinic allotting for the primary care provider and nurse to take part in the research. Clinical system information is used by gaining access to the individual's electronic health record and obtaining data needed on geriatric individuals in Milam County. Quality improvement takes place by establishing that based off the electronic health record, 65% of geriatric men and women who reside in Milam County have uncontrolled or poorly controlled blood pressure, and the prevalence of heart failure is already established in 1/3 of the population. Delivery system design is incorporated by determining several ways to reduce the prevalence of heart failure and to lower blood pressure to less than 140/90 in the population. Decision support is achieved when the clinic director reviews the data and supports the researcher's outcomes and goals with defined population. Self-management is supported and attained when participants self-measure blood pressure and self-report diet weekly with the primary care provider or nurse and make adjustments to his or her therapy based off of data findings. Community resources are established when other agencies become involved with the research. An example would be public transportation bringing the patient to and from appointments, or other entities helping to provide funding or staff to aid in data collection and other avenues of the outcomes. The two interventions, self-measuring blood pressure and self-reporting diet, are linked to other healthcare services. The intervention of self-measuring blood pressure was teamed up with the American Heart Association, and Milam County received 2,500 free blood pressure machines for participants to use when taking their blood pressure. The intervention of self-reporting diet was teamed up with a company called MyFitnessPal and was given a free download of the company's mobile application and free use of the company's internet site on the World Wide Web. The information that will be collected from the population intervention plan is twice-a-day blood pressure measurements, food journal, medication compliance, and exercise. The clinic nurse and primary care provider will collect the information on the Wednesday of every week. This close monitoring will allow for initiation, titration, and compliance of medications, as well as encouragement to participants to continue to make healthy food choices. Routine follow-up visits will be every 12 weeks with their primary care provider. Annually, heart failure prevalence and good blood pressure control, which is less than 140/90, will be examined from study participants and those in the community who did not participate to evaluate if interventions are improving these outcome goals. Dissemination is the directed distribution of information and intervention materials to a specific population or clinical practice audience. The intent is to spread awareness and the associated evidence-based interventions on a wide scale within or across geographic locations, practice settings, or social or other networks of end users such as patients and healthcare providers. Just as the Community Preventative Services Task Force recommends interventions that engage community, individuals, and healthcare workers, the two selected interventions also aim to engage the local clinic and community population. Findings from the study will be disseminated to the local community in the same manner it was advertised: letter to individuals, local newspapers, radio stations, flyers, and television. Considering the worsening epidemiologic tendencies and increase in heart failure prevalence in society, escalating costs, and continued poor quality of life and outcomes for these patients, the significance of heart failure prevention cannot be overstressed. This will require efforts in all levels of the prevention continuum, ranging from advocacy efforts to research. Population-level efforts, at-risk factor prevention, and adoption of healthy lifestyle habits are essential to promote overall cardiovascular health and reduce heart failure risk specifically.